Hello, everyone, and thank you for allowing me to participate in the Us versus HPV Prevention Week. My name is Dr. Erin King-Mullins. I'm a colorectal surgeon in the Atlanta area with my newly founded practice, Colorectal Wellness Center, and I'm here to discuss HPV-related anal cancer, a surgeon's perspective. I do have a disclosure that I am a paid educational consultant for THD America. So, statement of the problem. Why do we care about HPV in anal cancer in women? Well, as you can see here, the trends are that women are actually twice as likely to get anal cancer and about 1.5 times as likely to die from anal cancer as compared to their male counterparts. So today we'll go through a few things. We'll discuss HPV and anal cancer, the background and the prevalence of it, risk factors for anal dysplasia and cancer in women, screening modalities, how we're going to follow up and watch these patients, and how we're going to treat and prevent it. And a lot of the discussion today will be focused on the female population, given the fact that I'm representing the American Medical Women's Association. So let's talk about background and prevalence. So there was a study several years ago based out of Hawaii that looked at about 1,300 ethnically diverse women, and they wanted to see what is the prevalence of HPV disease, both in the cervical area and in the anal and in the anal area. Surprisingly, about 27% of women had anal HPV, and those with a cervical infection were had 3 times the risk of having anal infection. So, what are our risk factors for anal HPV? Increased number of sexual partners, younger age at first intercourse, history of chlamydia, anal genital warts, and what's going to cause the persistence of the HPV disease once it has been acquired? Lack of condom use, coexistence of cervical HPV, and alcohol use. And so when you see here at the bottom, the relative risk of acquiring anal HPV after having a cervical infection, so with the same genotype or the same strain of HPV, is about 20 times. So the thought process here is that the cervix serves as a reservoir for the anal HPV infection. So this means that a patient does not necessarily have to engage in anal intercourse to have anal HPV. About 90% of anal cancers are going to be caused by oncogenic strains or the high risk strains of HPV, with type 16 being the greatest at 75%. UC San Francisco looked at meta-analysis in 2015, and it looks like the median age of diagnosis of anal cancer is 60 years of age. So only about 1% of anal cancers are detected before the age of 35, which means there's time to detect and intervene. That's in comparison to cervical disease, where about 14% of cervical cancer cases are diagnosed younger than the age of 35, and the mean age of diagnosis is 49. So what are our risk factors? So there's two broad classifications. There's going to be immune suppression and then having an HPV infection. So our immune compromised patients are going to include patients with a solid organ transplant. And it actually has been found that this is related to or associated with higher risks of all the HPV associated cancers, so oropharyngeal, penile, anal, and vulvar. And the older immunosuppression regimens were actually at higher risk of having deleterious effects. Other groups that are going to be at risk will be patients with autoimmune disease and those with hematologic malignancy. But the biggest risk factor is having a cervical or gynecological disease from the HPV. So women diagnosed with anal cancer are 10 times more likely to have had a history of lower genital tract cancer. And you see the highest rates are actually those with vulvar disease, so vulvar cancer or vulvar high-grade dysplasia. And that's due to the proximity of the vulva. It's much closer to the anus as compared to the cervix. So how are we going to screen these folks, and what are the recommendations for such? So the most basic way is examination. You're going to look, you're going to feel. So there was a study looking at men with anal cancer, but Berry et al. Reported that a mass, some sort of abnormality was identified in about 85% of those with anal cancer. Well, we want to detect changes or abnormalities prior to being able to physically see or feel them. And so we're going to start out with cytology, an anal pap, very similar to the cervical pap. We're going to get some cells and send them off to the lab for evaluation. And the reporting of those results are very similar to the cervical disease. Next step, if there's an abnormality, how we're going to look a little bit closer. The high resolution anoscopy is analogous to the colposcopy. It's going to take a high definition camera to look more closely at the cells for abnormalities that can't be detected with the naked eye. There's actually no official guidelines for screening for anal cancer, so a lot of what we do is based upon anecdotal evidence and mirroring what we know about the progression of HPV in the cervical area. The American Cancer Society recommends that those at risk for AIN or anal dysplasia and anal cancer might benefit from screening, but there are no randomized controlled trials to prove this as of yet. So this is my favorite slide of all. This study actually looked at women that were newly diagnosed with cervical cancer and looked at what would happen if some of them got screened for anal cancer and anal disease, and some of them went unscreened, okay? And so let's bring my annotation device, tool back up here. And so if we're looking at, this is the diagnosis of the cases of anal cancer. And then these are the years of them being active in screening. Okay, so these are the years from their diagnosis of cervical cancer. The blue line is the unscreened population, meaning the people that were not looking for anal dysplasia or anal cancer. And the orange is the screened population. So you hear right at about the 5, 6, 7 year mark, you start to see a divergence here. The blue population is being diagnosed with anal cancer. So that means in the orange population, this orange group, something's happening with this screening that we're being able to see and detect something and treat something prior and preventing anal cancer diagnosis. And then on this other box, we're starting to see this first grouping is looking at anal cancers being developed. And then the second group comparison is looking at anal cancer deaths. And so again, here about a 6 to 7 year mark, you're starting to see a divergence in those actually being diagnosed with anal cancer. So those who are being screened are less likely to develop the anal cancer, and those who are being screened are much less likely to die from anal cancer. So what do we do with these results? Well, if you get an anal pap, there's different pathways, and I'm not going to go into the full details of this screen, but it's a little bit busy. But, if it's a normal cytology, if they're a high-risk patient, you're going to keep an eye on them. If there's something that's abnormal, you're going to determine whether or not you're going to proceed with the high resolution anoscopy. So especially patients with the immune compromise, but any major abnormalities in the anal pap, you're going to proceed to the high resolution anoscopy, which again is analogous to the colposcopy. So the results of the high resolution anoscopy, if there's only really low grade changes, meaning the patient's body is keeping everything in check, then you're just going to repeat the exam in 1 year. If there's any sign of high grade dysplasia, then you're going to proceed with a rectal examination under anesthesia with biopsies and ablation, basically getting rid of those abnormal areas to prevent the progression to anal cancer. So these are just some pictures from a high resolution anoscopy. Similar to the colposcopy, we'll use acetic acid, which is vinegar, to initially stain the cells. You go over it with an iodine-based solution, and any areas that aren't uptaking this iodine, like these, let's get my annotation device. So these highlighted areas, those are going to be abnormal. That's where you're going to biopsy. That's where you're going to be concerned for high-grade dysplasia or precancer. And here's just another picture pointing out some abnormalities, and they were biopsied and did show some dysplasia. So how are we going to treat this? So for the dysplasias, there are some topical treatments that are available. There's an oral treatment that was under investigation. It wasn't quite as effective as the topical, but it is available in certain situations. For high-grade lesions, so those that have progressed beyond the ability of the body being able to control it, and it's inching towards anal cancer, You want to ablate or burn, cauterize, laser. You want to get rid of those areas to stop the progression to anal cancer. And once you've reached anal cancer, the primary treatment is actually chemotherapy and radiation. It's called the NIGRO protocol. Those who do not respond to therapy or have recurrent disease after they've been treated with this need to go on for a salvage therapy called an abdominal perineal resection, where you remove the anus and the surrounding tissues, and the patient has a permanent colostomy. But the key to all of this is Prevention Week. How do we prevent it? The same way we prevent the cervical disease, by the bivalent or quadrivalent vaccine for high-risk HPV, currently recommended for patients up to the age of 45 for both men and women. But primarily, we want to see these vaccinations happen prior to sexual intercourse and sexual activity, so about the 9 to 12 range. We want that in men and women, or boys and girls. So that's all I have. Thank you so much. I know I went through a lot, but I just really wanted to give a great scope of anal HPV and the risk of anal dysplasia and cancer. Thank you so much.